Hi guys, this is the chapter on blended competencies, clinical reasoning, and the process of patient-centered care, which they're moving from patient-centered care to person-centered care. It'll take me a while to get used to that. Here are the learning objectives for our chapter. Please review these and make sure that you understand these so that you have the chapter content down. Also remember to go over the key terms and familiarize yourself with any that you don't know. Nursing has evolved over the centuries to be a very diverse and expanded role. It's part of why I love nursing so much. I have changed roles multiple times in this career, and each time I change, I gain so much more knowledge and experience and an appreciation for what it means to be a nurse. The American Nurses Association has listed these as some key features in the definition of nursing. Take a moment and read through them. I think they all apply to being a nurse today. It's a little bit dry. We'll try to make it more interactive as we go. Okay. Our patients will always be at the center of our care. We look at the whole person, and I feel like in a way that makes our role really unique. We don't just look at the disease process or the illness they are dealing with, like medicine does. We have to be really thoughtful in our care and in our interactions. Each patient is an individual that comes to us with unique needs and strengths, and we have to identify those and work with the patient or the person to provide the best care that we can so that we can ensure that they have optimal outcomes. You've already had your ethics and legal lectures, so take a minute and go to your textbook and look at the reflective practice skills on the challenge to ethics and legal issues, and then review the components of thoughtful patient-centered care to get a deeper understanding of what that means. The chapter in your textbook reviews the 10 principles in patient-centered care. Definitely look at those in the book as I go through the steps and look at how you can incorporate these principles in your nursing care. First, it goes over the fact that all of our care members are considered caregivers. Everyone is a part of the caregiving team, from housekeeping to management. They all contribute to the patient's experience and their care. And care is based on relationships. If you developed trust and had good interactions with your patient and their families, it will make a difference in their stay and their outcome. No two care plans are ever exactly alike because no two people are exactly alike. We have to customize our care to our patients' needs. We rely on the care team members to help us gain knowledge, and our patients rely on us to relay that knowledge to them. And I'm just going to pause right there to say, I can't tell you how many times I would be in a patient's room and the doctor would come grab me and say, hey, come in this other patient's room with me. And they would come in for 30 seconds and say whatever was wrong with the patient in medical speak, and then they would leave the room. So when that happens to you, which sadly it will, but those doctors have way more patients than we do, and you have to remember that. Stay and make sure that they understand what that doctor just said to them. And go take the time to explain it, and then if there's more questions than what you can answer, call that doctor and ask them to come back. So when I say a healing environment, what image comes to mind for you? So think about that. What's a healing environment? Is it a supportive, restful, comfortable environment? I hope so. That's what we need to help create for our patients. And it's not always easy in a busy, stressful hospital or care setting. So, if you work nights, are you dimming the lights? Are you taking care of all those beeps and noises that are going off around the unit? Are you ensuring that the smells are controlled? Are you ensuring that the temperatures are good for your patient? What else can I say? Are you bringing them a warm blanket? Do they have a drink if they're allowed to have fluids? Those are the kind of things. What is it going to, and ask them, what would make your stay more enjoyable or comfortable for you? Now, maybe enjoyable is not the right word. Does anyone enjoy being in the hospital? I don't think so. But we want to provide the right environment. Friends and family need to be incorporated into our care plans, absolutely. And they have to be considered an extension of the care team. Another thing I can't really say enough is that I feel like we don't listen to the families when they are saying things like, this isn't how they normally are, or I'm concerned because they seem different than they were yesterday. Don't brush off those comments, because who knows that patient better than anyone? Their friends and family. So make sure that they are part of the care team and that they are not discounted for the things that they're saying to us. Patient safety is always number one. We always assess for possible threats and then make sure that we have proper processes in place and we're following them to keep them safe. So if our patient is a fall risk, which really most people are, then what are we doing to make sure people know they're a fall risk? So maybe they have to wear yellow socks because that's a fall risk indicator. We put a little special sign on their door. We put a special sign on their whiteboard. We write, call, don't fall. We make sure they have their call light. We make sure their bed alarms are on. We make sure the bed is in low. We might have fall pads on the floor. What else? We might move them closer to the nurse's station because they might not have the capacity to realize that they're a fall risk and they may be impulsive. So I want to move them closer to where if my bed alarm goes off, I am seconds away from getting there to avoid a fall. All of the things. So, we have to keep the patient informed and up to date in order for them to make good decisions. And we always keep our patient's best interests in mind when we are providing care. We regard the patient with autonomy and as the person in control of their care needs. Now, when I say that, if they are not alert and oriented, then they are still treated with respect and dignity at all times, but it's hard to say that they're in control of their care needs. We need to be their advocate in that situation, and we need to make sure that their family is definitely a part of their care. Okay, this slide goes over the International Association of Human Caring's beliefs regarding caring. Take a minute and read through these. Do you agree with them? I like that they consider caring the essence of nursing. Your patient is not going to remember the nurse that got the IV. They're not going to remember a lot of things about their stay, but they will remember the nurse that truly cared about them and listened to them and was an advocate for them. Person-centered care begins with our patients in the center of all of our thoughts and actions. Every nurse will bring different attributes to their caregiving. First, it starts with your personal attributes. Do you know your own values and beliefs? Can you question authority, or do you have a tendency not to speak up? Do you take responsibility for your own actions? Are you open-minded? And I want you to really take some time to think about that, because later when we talk about biases or your knowledge and beliefs about something, I know I had someone say to me one time during that session during class that they didn't have any biases and that they had no prejudices. And my response to that was, that is your bias. And it is, because you have to be aware. We all have them. We formed them early in life. And by the time we're 6, really, we are who we're going to be. We can absolutely change some things or be more aware of things. But those biases are there because they're ingrained in from our upbringing. So really think about it. Because nurses have to have competencies in cognitive, technical, interpersonal, and legal areas. We have to put our own thoughts aside and go with what does our patient want and be an advocate for them. So if you're one of those people that doesn't speak up because you are going to defer to authority, then you are going to have a hard time advocating for your patient sometimes. So with that example I gave it on an earlier slide where I said, when the doctor comes in and delivers some message and it doesn't make sense to them, stay and explain it. And if they have more questions, you have to say to the doctor, hey, you came in here and you were very brief and I stayed and talked to the patient, but they have a lot more questions. I need you to come back up and talk to them. If you're not comfortable having that conversation, then it's not going to be the best for your patient. So you always have to look at overcoming your own personality, basically, to do what's best for your patient. So if you stay patient and person-centered, it'll help you with those things, even though they may not be your natural tendency. And you'll get better about it over time. So we will go into more detail on all of this on the next slide. The cues and competencies are developed to round out your knowledge, skills, and attitudes in nursing. You're going to use your clinical reasoning skills and all of your learned skills and personal attributes to make sound decisions on patient care needs. Then you're going to apply the nursing process, which Belinda is going to talk to you about, to create a plan of care and deliver the care, and then evaluate the care. Then you'll go back to reflect on the patient outcomes and learn from it and make adjustments next time to grow or use the successes to plan for their use again in the future. Blended competencies include cognitive, technical, interpersonal, and ethical legal competencies. So the knowledge you gain in nursing school and through continuing education will help build your cognitive competencies. You will need to develop critical thinking skills to develop your thoughts, to identify your goal, and to make good patient care decisions. You have to always ask, what if, and plan for those circumstances. Your textbook has a good description of how to develop critical thinking skills, so take a minute and read through that in this chapter, because it's essential for you to develop these critical thinking skills in nursing. I feel like the tests are very difficult. We will probably say that 100 times, but until you really get into how the tests work, you won't understand that. But a lot of how the questions are developed is to help hone your critical thinking skills. There's also a list of attributes of a person possessing critical thinking skills, so look at that as well. Technical competencies can be gained through practice. So you get that muscle memory the more you practice. So just keep practicing your skills. We're going to have a lot of checkoffs this semester and throughout nursing school. And the more you do it, the more you become competent in your the way you're doing things, the more it'll become second nature to you. So one of the things you'll hear us say a million times is that hand hygiene is the way we break the chain of infection. So get in the habit of always doing hand hygiene. If you put on gloves, you're going to wash your hands before that. If you take off gloves, you're washing your hands after that. If you touch the patient and then you go to touch something else, you better wash your hands in between that. There's all kinds of times you need to be washing your hands when you walk in the room and when you leave the room. So your hands will be dry. Just know that. Get a good lotion. That's my words of advice. Let's see what else is in here. So here's some of the skills you're going to learn in this block: medication administration, injections, and Foley catheter insertion. So you really have to take the time. We're going to have a lot of time in lab to practice those skills, but come into the practice lab and sign up with a group of students so that you can continue to practice that. Because when we go to check-offs, you're going to be nervous because we're going to be watching you and you're going to think, oh, I hate having people watch me while I'm doing stuff. But the more you practice, the more confident you'll be, the quicker it'll go, and probably the better the outcomes are going to be for you. Interpersonal skills are essential too for a nurse because you have to establish trust and build rapport with your patients and their families. We need to respect the human dignity of each individual and show them respect at all times. So direct the conversations with your patients to really get to know them and show genuine interest in their lives and in helping solve any problems that they may be facing. The textbook has some great questions you can ask the residents when you go to long-term care. And it's under the Establishing Caring Relationships heading. So go there and look through that and bookmark those so you can return to them later in the semester when you'll be going out to long-term care. It'll help you start the conversations. I also tell the students to consider that patient to be your beloved grandmother or grandfather, mom or dad or brother or sister. How would you want them to be communicated with and treated? That is how we should treat each one of our patients, even though they are strangers to us initially. Also, as a nurse, you need competencies in ethical and legal areas. You must be accountable for your own practice, and that's a huge responsibility. And this includes staying current with the Nurse Practice Act, your agency's policies and procedures, patients' rights, and completing accurate and timely documentation. That is huge. Cues and competencies. You'll hear us talk about them a million times throughout nursing school. So cues and competencies include those listed on the slide. So once again, we start out with the patient being the center of everything we do. That doesn't change anywhere, except for to say person-centered instead of patient-centered. And then you have to learn to develop teamwork skills and collaborate with the other healthcare team members. So in order to do that, you kind of need to know what's my role versus what are all those other people and what do they do. And I just recorded something that you'll have, I think, at the end of this week, or maybe it's in there already, that is who's who and what do they do. You need to know that. Nurses do not work independently. We need to help each other as nurses to provide the best care possible for our patients. And not just the nurses. We need to know when to engage other members of the interdisciplinary team. We are always striving to improve our care and improve patient outcomes. So quality improvement is a huge part of our job. Safety is also a factor in planning and providing patient care. We have failed our patients if we cannot provide a safe environment for them. So you'll learn later that we have never events, or what we call sentinel events, in the healthcare environment. Never events are things that could have been prevented, but they happened. Same with sentinel event. They're an interchangeable term. And anytime we have an event, such as a never or a sentinel event, it requires us to do an incident report. An incident report is filed outside of the patient's chart, never mentioned in the chart, and it goes to our risk area so that we can look at what happened in that instance and how could we have prevented it, so that we can look at our processes. It's not meant to be punitive, it's meant to be a learning opportunity. So technology is a great a great asset in healthcare. It helps improve care, decrease human errors, and provides information at our fingertips. You have to be knowledgeable. You have to be knowledgeable about the technology available to you and how to use it properly. The textbook describes a lot of these competencies in great detail. Take a moment and look those over. This is part of what our curriculum is based on and what competencies you should possess. It says at the end of nursing school, but truly, we rate you on these every time you are at clinical. So don't be surprised if your clinical instructor doesn't give you great, like you're satisfactory and everything right away, because these take time to develop, but you need to know what each of them are. This slide reviews the clinical reasoning cycle. This is how you will be thinking as nurses. First, you consider the person's situation. So when you walk in the room, you're collecting and gathering information from the second you walk through the door, maybe even before the door. Maybe you're hearing them yell out, or maybe you smell something before you get to the door. All of that is information you're assessing and gathering. Then you identify the problems and come up with goals that you would like the patient to achieve. And not only that you would like the patient to achieve, but who would like them to. You better be working with your patient. Then you plan your actions and then you act upon them. After you do that, you have to evaluate if they worked or not and whether the goals were achieved or not. What if they weren't? Who do you go back to? You better go back to your patient. You go back to your patient and you say, were these goals specific enough? Were they able to be measured? Were they attainable? Were they realistic? And were they timely? If they were not those SMART goals, then they need to be reevaluated and maybe changed. And the best person to be working with to update those goals is your patient. So maybe the goal was to get them up to meals, up to the chair for meals. And you go back and look and that goal was not achieved. They didn't get out of bed today. Well, maybe they developed diarrhea, so they're not getting out of bed. They have a SOSI tube in because it's uncontrollable and they have C. diff. Whatever the reason is, you go back and see, why didn't we achieve this goal and how do we need to revise it? That was kind of a off the top of my head goal. That's kind of gross. Sorry. All right. Then you learn from your goals, then you go back and see if you could have done anything differently. And you'll see soon that this process is the nursing process. And we're going to get really in depth on that to the point where you'll be like, why do we have to know all this so much? But you'll know why later when you're a nurse. So really get to know it. Clinical reasoning and decision-making is a process. It's used to think about patient problems in the clinical setting, and it leads to proper clinical judgment with an outcome of critical thinking, clinical reasoning, and decision-making that is purposeful, informed, outcome-focused, and it's guided by standards, policies, ethics, codes, and laws. And it's driven by our patients, their family, and our community's needs. Our community is our patient too, really, if you think about it. These needs are based on principles of the nursing process, problem solving, and the scientific method. And it focuses on safety, quality, reevaluation, and self-correcting. We're always kind of reevaluating how we're doing. How are we doing as a nurse? Where do I need to focus to ensure that I am the best version of a nurse that I can be? Excuse me. Clinical reasoning and decision-making involve identifying key problems or issues and risks. So that's patients, families, and key stakeholders in decision-making. We involve them all early in the process. And the process of clinical reasoning and judgment uses logic, intuition, and creativity. But all of that is grounded in our specific knowledge, skills, and experiences, which a lot of you have some of that already, and many of you will hit the ground running to get all of that. And then we take all of that and form strategies that make the most of our human potential and compensate for problems created by human nature. Problem solving can be approached using different methods. First, there's trial and error. And this is not that effective in nursing because we're dealing with people's lives. Hello. I mean, do we want to try this and see if it works? We do. We do that with medications sometimes. But if we make an error, it can be harmful to our patients. So scientific problem solving is a systematic 7-step process of solving problems. So first you identify the problem, and then you collect data, form a hypothesis, develop a plan of action, test the hypothesis, and interpret the results and evaluate the results. So if that looks familiar, it should. I hope it does. Intuitive problem solving is based on a nurse's knowledge, background, experiences, and skill. So know that. Intuitive problem solving. Knowledge, background, experiences, and skill. So you have to have all three of those to be able to say, I know it intuitively. So if you're a student nurse and you're like, oh, my intuition told me that. Well, it could, and you might be right. But in order to have credibility in your intuitive problem solving, people have to know that you have the knowledge, background, and skill. So it's that gut feeling that something's just not right. And then you seek out validation for a feeling the way you do. Critical thinking is based on being logical and scientific, but it also includes an element of intuition. Tanner's clinical judgment model identifies the processes of clinical judgment that reflect the way nurses think in practice. As students learn to think like a nurse, the processes develop from noticing to interpreting to responding and then reflecting. Noticing is a perceptual grasp of the situation at hand. It's the process of perceiving important or salient aspects of the situation. So noticing is kind of what I said on the last slide. It's as you become more adept in your assessment skills, you're going to walk in a room and notice within 10 seconds 10 things that are an issue. When you're new, you may not recognize more than a couple, but eventually you may not even need to lay hands on the patient before you know the priorities for the day. Interpreting is the development of sufficient understanding of a situation to respond. So it's the ability to take the data in a situation and then determine the etiology or the underlying cause, patterns, additional factors to consider, or additional information needed, whatever you need to draw a conclusion. So interpreting. I notice that the patient is wheezing from the door. So wheezing is an adventitious breath sound that is not something you want to hear. It's an out of the norm sound. So when I go in and glimpse in at my patient, I see that from the door, they appear to have labored breathing. I'm counting respirations and I count 36 respirations. I notice that they also appear to have edema or swelling in their extremities. And it's really kind of generalized edema. And I notice they have fluids running at 125 mLs per hour. So as a nurse, I interpret all of that and I think, could they be in fluid volume overload? Maybe they need to turn those fluids off and they are holding on to too much fluid. Why are they wheezing and why is their respiratory rate up? Well, I need more information. I want a set of vitals. I want to know if they have a fever. I'd like to get lactic acid, which will tell me if they are in respiratory failure or if they have, maybe I need to know what their chest x-ray looks like. Do they have pneumonia? I need to look at a lot of different things. But as you become a nurse and you hone your assessment skills, you're going to know, this is what I see, this is what I suspect, this is how I confirm it. So, and then you have responding, the ability to decide on a course of action, including no action. So maybe I hear wheezing from the door And when I look in, it's my COPD patient. They are, they're at 90% on 2 liters nasal cannula, sitting on the edge of the bed, and they tell you that they're fine, they don't need anything. Well, guess what? That's probably their baseline. So I don't need to do anything. But responding requires you to consider the situation and what are the goals of the patient, what's the response and intervention, and you have to develop a plan of care. So you have to know the stressors that are being experienced and then how to respond. Reflecting. So that is the attention to the patient and family response. So how did the family and patient respond to the actions you took? It's the ability to identify what you did or how you responded to what occurred and how you might need to adjust it differently in the future. The nurse identifies what additional knowledge or skills are needed, and it includes reflection on values and feelings about the situation. The nursing process systematically collects patient data through assessing, identifying patient strengths and actual or potential health problems and needs, which would be nursing diagnoses, developing a plan of individualized care that specifies the desired patient goals and related outcomes, and the nursing interventions most likely to assist the patient to meet those expected outcomes, which is your planning. Executing the plan of care or implementing it, and then evaluating the effectiveness of the plan of care in terms of patient goal achievement. So you're evaluating. I think I just read you the slide. I'm sorry. But the nursing process is what we use here at MCC to make sure that we are doing a great job of assessing our patients and then identifying their priorities of care, working together with our patient and interprofessional teams of caregivers, including the family and the patient in that interprofessional team, to plan for what we want to see for our outcomes, then implementing that plan, and then evaluating whether or not it was successful. If it wasn't successful, again, we go back to our patient to review what happened and maybe revise or just reinforce the goal. We are only humans, so we need to identify some possible errors that can occur in decision making. I talked about this a little bit earlier. Biases can include being predisposed to a single solution or a past solution. It could include avoiding data contrary to your own opinion, or placing emphasis on certain data, and selecting a path that maintains the status quo. Failure to consider the total situation includes using inaccurate or incomplete data, not identifying the problems properly, not getting the importance of the problems, or not in the order, or creating an unrealistic goal for your patients. Maybe you identified the problems, but you didn't place importance on one that really was the important one. So impatience can occur when you don't look at multiple solutions, or you incorrectly implement the decision and not use the appropriate resources available. So those are biases that you might have that you need to be aware of. So if you find that you're consistently impatient, go back and review, what am I not doing, or what could I change to decrease that impatience? This slide goes over how the nursing process as we know it today was developed and evolved. It's interesting that the nursing process or the solving process in care delivery wasn't really examined or put into certain steps until the 1950s. And you're going to hear us use the term ADPI a lot in the coming weeks. This is the nursing process, and that stands for assessment, diagnosis, planning, implementing, and evaluating. We will go into detail in the coming chapters on each one of these steps. For now, I want you to pause and read these over. Write down the definition for each one if it helps you remember. If you're not a read-write person, at least make a note of it and start to get familiar with the terms because we're going to use them all the time. We call the nursing process a systematic and dynamic process. It's also very interpersonal. We work with our patients to promote health, prevent diseases, and restore health and facilitate their coping with any changes in their healthcare status. So, of course, we would like to prevent our patients' health from becoming a problem through prevention. We do that early. So if you think about it, what are some different ways that we prevent diseases? Maybe come up with a list. How do we promote health? And then how do we restore it once it isn't good? And then what are some coping things that we would need to help our patients with if their health status changes? The nursing process is systemic because it has set steps. I said that wrong. It's systematic. It's not systemic. It's dynamic because there's a lot of interaction between the steps, and sometimes they overlap, and you go back and forth. It's interpersonal because it's based on each person's unique care needs. And it's outcome oriented because we always have a goal for our patients to achieve. And it's universally applicable because it can be done in various healthcare settings and with various types of patients. This slide, I don't have any really huge talking points, but it's a good slide to become very familiar with. Maybe take a picture of it and review it occasionally. I'm going to have some cards that we're going to use during class when we do case studies that will have this noticing cues and recognizing cues and all kinds of things that will help you start to put this nursing process in place using the clinical, critical judgment needed by nurses. Concept mapping is going to be one of the things we're really going to get into later on in the semester. And concept mapping takes the nursing process and focuses on the whole patient, and it creates a clear plan of care. It benefits the nurse because it defines our work and it allows us to work with other disciplines, and we can see the outcomes of our efforts in our patients. So actually that was just benefits the nursing process. Here's concept mapping. Concept mapping graphically displays the links and the key concepts of the problem or the process. This is, I feel like concept mapping kind of takes all of the different learning styles and puts them into one. So if you're visual, you can take a one-page thing and make it in something you can visualize in your head. If you are read-write, you're writing it all out on one piece of paper, and it allows you to read it. And if you're visual, again, same. If you are kinesthetic, then you can picture how you would implement these steps as you put this in place. So concept mapping graphically displays and links the key concepts of the problem or the process. In nursing concept mapping, you will need to identify what the diagram looks like. You're going to analyze and categorize your data and look at the nursing diagnoses, relationships, identify goals and interventions, and evaluate the patient response. So I placed a picture of a concept map on this slide regarding bowel elimination. I'm more of a linear thinker, so I found concept maps can be confusing, but if you find that between the examples of the book, this example leaves you feeling the same way, don't worry. In nursing, there are many ways to approach patient care and documenting, and you'll learn how it will work or how to work with all of them. Actually, I truly like the concept mapping, but not in every way. I like to do it where I take a disease process and then I say, what are the signs and symptoms I expect my patient to display And then what caused that? Why do they have it? What happened with anatomy and physiology to create this disease? Then what do I think the labs are going to look like? Or what lab work do I need to look at? What are my nursing priorities if they have this disease? What diagnostics do I expect them to have? Maybe. And then if they have to have diagnostics, as the nurse, what do I need to make sure they know? What medications do I think they're going to be on? What are the side effects of those medications? What are the expected outcomes using that medication? What do I need to tell my patient about the medication? What do I need to assess if the patient has this disease? And one of those things I'm assessing is how well did that medication work? Are their symptoms resolving or aren't they? So that's what I like about it, because I can picture on one page all the things I need to do for my patient. What education is going to be key for them, because we are educators, all of us. Last but not least, let's talk about reflective practice. This is a purposeful activity to help us improve our actions and practice, understand it better, and learn from it. We have to take some time and reflect all the time, and that's why I like to say it's great if you have a day timer. I know that term is from the 90s or the 80s. I still use it. We need something where we are journaling or just taking a moment to ourselves to reflect. So reflect on the actions that happen during you performing something. Reflecting on that action occurs after you think through a patient situation from the past. So you reflect on what made you think to do what you did. Were there alternative things you could have done so that in the future you might have a better patient outcome? Did you keep your priorities in mind, or did you forget about the priorities? Really think back. Why did I choose to do the way I did? We're going to do reflective practice a lot in our simulations, because the debriefing part of simulation is where we really go back and say, why did you think to do it that way? It's a non-judgment zone. It is a confidential place, but it's where the real learning takes place. And we try to get your knowledge ingrained so that that practice that you had helps you to build your confidence, your skills, your knowledge, and your competency in practice. So reflection is a great tool for you to be using. I want you to look in your book at the Delaware County Community College Nursing Patient Database and the resulting concept map care plan. Listed under each problem is a nursing diagnosis, a short and long-term goal, and the nursing interventions chosen for that problem and goal. This is a good introduction to what we will be doing this week in clinical lab to start practicing putting the nursing process together in action. So that's the last slide for this chapter. You made it. Sorry, it's 45 minutes long. I'm a talker.